tuning in to an episode of Pineland University. So today we're going to be talking about ketamine and the effects of ketamine, how to use it analgesically, how to use it in general. All right, so my name is Kenny. I was a Special Forces medic for a long time. I got quite a bit of extensive use and experience with ketamine. And today I got with me today is Dr. Mickey. He was a Special Forces medic as well. Decided to go to medical school and here we are. So hopefully we're going to drop a couple knowledge bombs on you and see what we can come out of this thing. So, hey, Doc, what I wanted to talk about is I've used ketamine a few dozen times, and I've spoken with a lot of other folks that have used ketamine quite a bit and done a lot of research on it. And so we're talking to the folks at home, and we're going to talk about it in an analgesic state, right? So the way that I look at it, so first off, guys, you know how it works. Right? So ketamine works as it binds to it's an antagonist of the NMDMA receptor, which means that the nerves on the brain are not going to be receiving the pain from the body. It's actually going to give you an out-of-body experience from the environment and an out-of-brain experience from the body, depending on the amount that you take, right? Just like anything, right? You drink some beers, some Mai Tais, some rum and cokes, whatever your poison is. The more you have, the more disassociated you are. So this is kind of the same thing, right? So this is actually, it came right after PCP. So this ketamine started in the 60s. And the way that it works is let's imagine the ketamine brain continuum, right? It's in 4 phases. So just imagine like an arc going up. And that bottom range is the analgesic range. That's what we're kind of looking for. And that's somewhere, and we can talk about the KIGs. Oh, it's like 0.5 mgs per kig and 2. I'm not going to weigh a patient on the X. It's just not going to happen. I'm going to look at him like it's somewhere between 7 and 15 mgs. Like, what do you have for that?
Yeah, no, so like ketamine is awesome. Like when we look at ketamine, especially on the military side, we look at it for 2 things. It's a great analgesic and it's a great anesthetic drug. It's hard because, we're familiar with this drug, in group, we use it very often. But when I transitioned over to the civilian side, it's a new product. It's something that's, not used as much and they're not comfortable with it. So, hopefully that we can dispel a lot of those myths with what we're talking about now.
Yeah, so like since the 1980s, I know that there's been pharmacology textbooks, and they say the same thing about ketamine. And it causes hypertension, increased intracranial pressure, cardiac depression. Basically causes the patient's head to explode, like right after, of course, they go crazy and kills off all the staff of a hospital. So, guys, that's not at all true. In matter of fact, back to the brain continuum in our little arch, about that 10 mg range is really great for analgesia. You still have a patient that's able to probably talk to you, function properly. You've just taken the pain away. However, that 7 to 15 mg dose that I was just talking about, you can kind of push that patient a little bit more into the next part of the continuum, which is going to be the recreational dose. So I don't know, if you push the patient a little bit more into the recreational dose, that's just fun. That's a bonus, right? I don't think anybody's going to complain about that, right? I mean, folks have been doing that since the 80s as well, in the 70s, going to the clubs and oosh, 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 right? That's how they get down on ketamine, and that's the party drug. So you're probably not going to have a lot of people complaining about that. What do you think?
Yeah, and that's what's crazy about it. So like when we look at it in the military side of it, we always have to outweigh our risks. Like, is the benefit to risk ratio, is it beneficial for me to, manage this person's pain or the soldier's pain as opposed to getting them back in the fight? And on the civilian side, our main focus is our survey. How is our patient doing? How are we able to establish a level of consciousness, and who do we need to send them off to? So that's a big factor, and that's what's great about ketamine, because ketamine, I could load you with the dose and I could maintain or achieve an analgesic effect. And the great thing is that it's loading, it's rapid, and as far as it, maintaining, it wears off fairly rapid as well, between 15 and 30 minutes. And that's why it's great for, managing pain or even doing small procedures or even large procedures, depending on the situation.
So I've heard Dr. Weingart talk about maximum aggressive care everywhere. And simply put, using ketamine as an analgesic will allow you also to do some more aggressive care, because there's many times where folks are going to put, that upstairs care downstairs, because we're putting upstairs care of a hospital on a pedestal. We're really thinking that these, ICU docs and nurses, now granted they're doing great things, but there's things that we can do to manage this situation, and we might need a little bit of analgesic help in order to make that happen. So that's why we're really pushing that max aggressive care everywhere. We're using this as a pain management tool. So let's talk about the next phase, which is going to be the partial dissociation rate. So imagine back on that little continuum that we're talking about, past the recreational dose, you've got the partial dissociation rate. And the partial dissociation phase is when you're still kind of, in lack of better terms, kind of with it, right? Your brain is still thinking that you're here, but you're also separated from it. And that can freak out a lot of people, right? I mean, it's a small number on average, but enough to where that psychoemergence reaction is a real thing. Matter of fact, I'll tell you this one story, right? So, again, I heard this from a doc that was telling me that they were sedating a patient and they were putting them into a full dissociated rate, which typically is about 1 to 4 milligrams per kilogram. And getting upwards in that slope at that partial dissociated rate, talking to the patient, because again, these guys typically are going to have this miasma of bad dreams that they're working on at the moment, right? That's why they're getting this. So the ortho doc pulls his foot and tries to reset this thing in place, making the patient freak out. Patient jumps off the table and starts baying and howling like he's a wolf, right? So it's pretty trippy stuff, man. So a little bit of Versed. So how much Versed are we talking about?
5 milligrams. It's a great, 5 milligrams to kind of help ease off that. But it's cool to look at the history. When, like Kenny mentioned earlier, if you look at the history, we started playing with anesthetic drugs, early on in the 90s or early 1900s. And when we look at like PCP, it has some pretty major side effects. And PCP was a preceptor for ketamine. So ketamine is supposed to be the newer drug with less effects, but you do have that range of patients that still have that effects, and that's where you get that combativeness, that altered level of consciousness.
So pushing beyond that partial dissociated rate is the disassociated stage. And at that stage, I mean, you're literally able to do operative procedures at that rate. And that's somewhere around the 1 to 2 mgs a kg. And at that point, you've got the patient into nystagmus. But there's a lot of problems that folks try to accompany that with. One of being apnea. So let's talk about the apnea right now. I know there's a case out there of one case at least of prolonged apneic response to a full disassociated rate. What does that mean? Patient stops breathing. All right. Well, so typically what happens in most every case that there is not a prolonged portion of apnea. You can almost set your watch to it. It's about 10 seconds. Just give them 10 seconds and they're going to take that breath. If you're going to use this for an advanced airway, well, then it's no issue at all. However, if you're using this for a procedural sedation, you're going to put back in a fracture or something like that, and they're fully disassociated. Well, that's something that you might want to consider. Just positioning typically is going to take that away. Now, the patient might be prone to it if they have prone to sleep apnea in general. Other than that, it's not typically something that you're going to have to worry about.
Like even looking at the, what everybody else is using, we give a small bolus or a large bolus to get them, kind of get them on board, and then just keeping them there. Because like you're saying, like once we get to that disassociate range, we have the risk of having those negative effects. So, just giving the example, like if you have a patient who's coming in and, or you're responding to a motor vehicle accident and they have a really bad fracture, and we have to airlift this patient out, it's kind of the bad time to get them loaded and then throw them on a chopper where they're going to get overstimulated as they come down. Like we said, you have anywhere between a 10 to 15, 30-minute window for the drug to take effect or for its effects to take place. And once they start coming down, you get below that dissociative range, now you're in that dangerous range where, you become combative, you become aggressive, and more so because you're being overstimulated from the different sirens, the propellers, and everything that's going on. So, it almost makes sense to, get them loaded on and then starting, like 20 mgs per 20 mgs every so often as you keep them at that range.
So let's talk about when you administer this, right? You need to talk to your patient. So you may have heard from your dad or whatever. Ketamine is kind of like an acid trip, right? It could be a spiritual awakening for some people. In fact, some patients have described it just like that. There's people that have paid for this. Hey, just let them know you get this for free, right? So the thoughts that they're having at the moment could shape the dreams that they're going to have during this trip, right? Which is one of the kind of the problems with acid is that as long as it was a kind of a lucid acid trip and you feel like you're controlling it, it's not a bad deal. But you could have a bad trip if all of a sudden you feel like the acid's controlling you. And the same with the ketamine, that's kind of how it's happening, right? So in a partial dissociated range, you have the world is, you're still kind of within the world, but it's all filtered through some bad dreams, right? So let's get that patient where they need to be, right? Tell them to surround themselves in their happy place, right? Whether it's bikini models on the beach, or whether for your other female patients it's the emotionally available men, a room full of those guys, right? Which we know that's only going to be true in a K-hole, right? So really, I think at the end of the day, we can say that the overdose range, all that studies, that's the only kind of the Swiss Army knife of drugs. That's the only drug that we know that you can put a pediatric patient at 10 times the recommended dose level, and there's going to be no side effects. And those little guys will just be gone on their trip a little bit longer, but they'll come back. So any of the side effects that we have are so negligible. Laryngospasm claims, glottic structures falling backwards. Again, just positioning, anxiolysis, just a little bit of benzodiazepine, a couple mgs of Versed, and then maybe an antiemetic. Really, that's some of the only other horrible things that have happened is when they come out of this, a patient has been known to throw up a few times. So would you even treat them with an antiemetic? Is that even something important to do?
You can. It just depends on the history. But, and again, like going back to it, there's great cases online. We found a case where a 50-year-old man was going in for surgery and a first-year resident accidentally pushed 100 milligrams per ml vial as opposed to a 10 milligram per ml vial. And so, end result was that the patient just, had to remain intubated and was, transferred to the ICU where he, later was extubated uneventfully and eventually discharged the next day. But you're looking at 950 milligrams loaded on this patient at once as opposed to 95 milligrams.
Right on. So I guess let's go ahead and sum this up. Don't be scared of ketamine, guys. You can't overdose this. Just put them in a good place. Put them in a good mental trip. Don't talk about snakes and spiders. So once again, let's run down the dosages. So a good dose for analgesic rate, if you're doing a bolus, right, just giving them a little bit in the IV line, 10 mgs, right? A little bit more than that, 20 to 30. You're certainly up in the recreational dose area, which should not be a problem. They'll probably enjoy that, right? They'll probably thank you for it. A better idea would be 20 mgs in a bag over 10 minutes, and let that be, a good infusion rate. Now, if you can get them a loading dose in that 10 minutes and then the same dose, so if you put 20 mgs and you ran that over 10 minutes, another 20 mgs as a continuous drip, over an hour, titrated that's probably going to be your best outcome. Your patient's going to have little to no possibility of having that psychoemergence reaction. It's going to be a lot cleaner, and everybody's going to be a lot happier. So, hey, Doc, we're approaching that 15-minute mark, unless you got something else.
No, that's great, man. Loving it.
All right, guys. Well, hey, thanks for tuning in. Hopefully we kept you awake, and we'll talk to you again next time. Take care.